Welcome back to our roundtable discussion. We're now going to explore practical approaches to current care of newly diagnosed multiple myeloma. We have a number of regimens listed for patients with newly diagnosed myeloma in NCCN guidelines. We're going to ask our panel how they themselves utilize some of these regimens in their own practice. But before we do so, I would like to see, for those who are transplant eligible, is there anybody that you would not recommend going down the transplant road today? So again, this time I'll go ahead and start with Ajay. So what is your take on the role of transplant today?
So we have always been believers of transplant, as we've shown long-term data, even with the 3-drug regimens, the transplant deepens the response, and we've been able to show that this improves the overall survival. When we translate this to a quadruplet therapy, we have clearly shown the exact same thing. By deepening the response, you're gaining those MRD negative rates, and you can get to translate this into a PFS and an overall survival benefit eventually. So how are we using the existing data to prove that point? If you compare the quadruplet regimens with Perseus, with MROS and Benefit, those are prospective randomized trials. So you're seeing those CR rates almost increase by 20% in the transplant eligible patients, even with a quadruplet regimen upfront. So those are the data that clearly tell us like transplant offers us that benefit of increasing those depths of responses by almost 20%. And that makes me feel that transplant should continue to be offered for every transplant eligible patient.
So I guess, is there anybody who has a different view on this? For transplant eligible patients, that transplant as part of initial therapy should be considered for every patient. Anybody seek to differ from that?
I would differ a little bit from Ajay. A young patient who is standard risk, in my practice, I don't necessarily push for transplant. This is obviously different recommendation from a relatively older patient, such as a 74 or 72-year-old patient who is approaching that age where we would never take that patient to transplant. In that case, if a patient is interested, I would definitely proceed with transplant upfront. But a younger patient, I could